Hypothalamic hypoglycemia, the second most common cause of hypoglycemia in the untreated patient. This is a series of case reports of a syndrome that has not been previously reported. The hypoglycemia here is not due to an excess of insulin, as in nocidioblastosis or insulinoma, or for that matter, insulin-producing tumors or tumors that produce insulin-like substances. These drops in blood sugar below 70 milligrams percent are random and are not due to any hormonal agent, as you will see. So this is the American Diabetes Association paradigm, which has caused untold suffering and death throughout the world. And this is quoted from their Diabetes Care article, January 2012. Hyperglycemia defines diabetes, and glycemic control is fundamental to the management of diabetes. In reality, hyperglycemia can be the result of a rebound from hypoglycemia. So this is very misleading and very damaging. It has been known for some years that the hypothalamus controls the output of insulin from beta cells and glucagon from alpha cells. A dysfunction of the hypothalamus is presumed in this condition of hypothalamic hypoglycemia, and it is a diagnosis of exclusion. What we see with close monitoring is that the patient's blood sugar will fall below 70 milligrams percent in the absence of exogenous insulin, agents which may lower the blood sugar, or diseases such as nocidioblastosis or insulinoma. This case history is that of Dawn O, a 49-year-old married registered nurse who complained that she wasn't feeling right and that she would wake up in the morning feeling irritable and kind of shaky for 5 months prior to her first visit. I've listed her symptoms here. She had impairment of short-term memory. She says, "I forget everything." Her daughter would tell her a story, and 4 or 5 times, and she would forget it. She would get lost while driving. She had impaired concentration. She would forget how to log on to her computer. She had anxiety attacks and feel tremulous during these episodes. These might last for an hour or more. She had depression and headaches and spots in her visual field in addition to blurring of vision. She experienced chills and diaphoresis, numbness and tingling of her extremities. On one occasion, she dropped the telephone. She felt tired and she had insomnia. In addition to that, she was gaining weight. This is the line graph from her Accu-Check home glucose meter. Notice the many red X's, the low blood sugars that are recorded. And I want you also to notice the irregular pattern that is the lows and the highs on this home glucose graph. Several years ago, I devised or modified a glucose tolerance test called the glucose tolerance test with insulin determination. And I did this in order to identify high insulin values during the test period. And you see here, this patient does not have high insulin values. In fact, most are rather low. However, what you do see are blood sugars which are low at 1 and 2 hours, well under 70 milligrams percent, 55 and 51 milligrams percent respectively. This is her continuous glucose monitor graph from December of 2011. And as you can see, this shows not only hypoglycemia, but rebound Somogy hyperglycemia. Some of the episodes of hypoglycemia are so brief that you only see the rebound. That's because the Dexcom meter only shows 5-minute averages. It can detect 1-minute values, but this has been programmed out of the meter in accordance with some order from the FDA, I'm told. However, you can see how irregular this is, and the marked variation in blood sugar well outside of the norm of 70 to 140. This is a brief computer analysis of the Dexcom graph you just saw previously, showing that the patient had a total of 50 minutes of mild hypoglycemia between 55 and 70, and neuroglycopenia below 55 milligrams per cent. This is the second recording of a continuous glucose monitor, and you see the profound hypoglycemia again with the marked Somogy rebounds in March of 2012. The patient is quite symptomatic. And again, a Dexcom computer analysis, March 2012, showing 150 minutes of neuroglycopenia. Again, blood sugars below 55. The Dexcom meter can only record as low as 39 milligrams per cent, so she may have had values well below that. This is the case history of Dawn R., 45-year-old Caucasian female, complaining of episodes of altered consciousness over 2 years. It has been worse in the last 6 months, she says. She's had impairment of concentration and impairment of short-term memory. She's not lost consciousness, and she does not have epilepsy. She has episodes of blurring of vision or double vision. She has muscle twitching. She snacks between meals. She wakes up at night to snack. She's depressed. She has flushing and diaphoresis. She has mental overactivity during the night and wakes up. She's irritable and has emotional outbursts. She has difficulty with her balance, and she becomes dizzy and lightheaded often. She has a history of a documented fall in blood sugar in 2009 to 53 milligrams per cent. This is the Accu-Check line graph over time, showing low blood sugars recorded by the patient at home as the red X's, and again, the regular pattern with both hypo and hyperglycemia seen. The glucose tolerance tests with insulin levels show no elevation of insulin at any point, and a drop in blood sugar to 63 at half an hour. Using the continuous glucose meter, which records every 5 minutes, you can see the pronounced hypoglycemia recorded and the Somogy rebounds again. A computer analysis of the recording shows that this patient had 295 minutes of neuroglycopenia, that is values below 55 milligrams per cent, in the 3 days and 17 hours that she was recorded. This is the case history of Linda T., a 52-year-old Caucasian female who complained only of pain in her neck and shoulders. She had an MRI which showed many lesions, characteristic for hypothalamic infarction. She had impaired concentration, impaired short-term memory, episodes of weakness and paralysis, numbness of the left side of her face. The left upper leg felt numb to her. She awakened from sleep to snack. She's been gaining weight. She has frequent headaches. She's depressed. She has anxiety, panic episodes, labile hypertension, flushing and diaphoresis, and she's irritable. In addition, she has periods of tachycardia and difficulty with balance. She was thought to have a TIA in the past, and she has dizziness with spots in her visual field. Note that Linda T's Accu-Check line graph does not show hypoglycemia, but the giveaway here, if you're following this in your patients, is the marked irregularity of the pattern with the high sugars visible. And these, again, are Somogy rebounds. This is Linda T's GTTID. Note no elevation of insulin in that column, but again, as with the previous patients, drops in blood sugar under 70 milligrams percent. This is Linda T's Dexcom graph from January 2012, and we always use the continuous glucose meter to confirm or find for the first time the hypoglycemia in a patient with a suspicious history. Again, note the hypoglycemia with multiple Somogy rebounds. This is the case history of Linnell H., an 82-year-old female complaining of extreme fatigue over the past 6 months. Her neurologist felt that she had left-sided weakness with a history of dizziness. She's had difficulty with ambulation. She has double vision and emesis with vertigo at times. She has nocturnal restlessness. She reported loss of singing ability, difficulty with chewing and swallowing liquids and solids. She has, as is so frequent in these patients, impaired concentration, impaired short-term memory, frequent headaches, episodes of tachycardia, difficulty with balance, dizziness and lightheadedness. She said that she felt like she was floating. She's had trouble swallowing for 1 to 2 years. She visited the emergency room on one occasion and said they could not find any evidence of stroke or heart attack. She had an EKG, which was normal, and a CT brain scan, which was negative. At the time, she had an extremely high blood pressure of 295 millimeters of mercury. It's quite common in patients with nesidioblastosis and HH, that is hypothalamic hypoglycemia, to run episodic hypertension, levels in excess of 180, 195, 200. This goes along with the hypoglycemia, which triggers an adrenaline release, and patients have had myocardial infarctions during these episodes. So Linnell H. had bulbar palsy resulting from impairment of nerves 9, 10, 11, and 12. She had dysphagia, difficulty with chewing, nasal regurgitation, slurring of speech, and choking on liquids. This is the April 2011 GTTID on Linnell H. Again, showing hypoglycemia in red and hyperglycemia in blue. This is the Accu-Check line graph for Linnell H, showing hypoglycemia as red X's and the irregular pattern with Somogy rebounds, sometimes extending of over 300 milligrams percent. Linnell H is January 2012. Dexcom continuous glucose monitor confirms the hypoglycemia and once again shows the Somogy rebounds that we've seen in the previous patients. Computer analysis of the January 2012 continuous glucose monitor shows that Linnell H had 55 minutes of neuroglycopenia. The mild hypoglycemia you see was 10 minutes. This is the January 4th, 2011 non-contrast brain MRI showing the multiple areas of hypoglycemia infarction in her brain. This is the case history of Stanley H., a 67-year-old male whose chief complaint was not being able to pick up his right leg for the past 2 years. He went to a neurologist because he said his body movements changed over the past year and a half. He began drooling, his voice was getting softer, and his movements slower. He complained that his manual dexterity was much diminished. He had intermittent tremors of his hands and around his mouth. He had balance problems. He had impaired short-term memory and some weakness of his facial and limb muscles. His legs and feet would jerk, mainly on his left side while sitting in a chair, and he had anxiety or panic episodes in addition to hypertension. Although no hypoglycemia was recorded on his Akachek line graph, you can see again the irregularity with the Somogyi rebounds. The November 2010 GTTID picked up the hypoglycemia. Once again, note that there is no hyperinsulinemia. The hypoglycemia he's experiencing is brought out very well here in the continuous glucose monitor of December 2011. This is the computer analysis of the continuous glucose monitor reading from December 2011. Note the 185 minutes of neuroglycopenia in the 3 days and 21 hours recorded. This is the continuous glucose monitor of April 2012 after several months of treatment. Note the improvement. This is the automated computer analysis of the April 2012 continuous glucose monitor. Notice that the neuroglycopenia is now reduced to only 20 minutes over 5 days and 20 hours. The brain MRI showed only minimal changes in 2010. This is the case of Cindy D., a 45-year-old female whose initial complaint was, "My right arm is always numb," and she had that for 3 years. She had a prior recorded low sugar of 49 milligrams percent, and she had impairment of concentration and short-term memory. She also complained of paresthesias of her face and extremities. She said her right hand goes numb occasionally, and she had some difficulty with balance. She was officially diagnosed as multiple sclerosis in 2006 and was under treatment with Copaxone. Again, the patient's home line graph recording shows episodes of hypoglycemia and hyperglycemia. And as is characteristic of hypothalamic hypoglycemia, her GTTID identifies hypoglycemia but no hyperinsulinemia. Short periods of hypoglycemia are picked up on the October 2011 continuous glucose monitor with prominent Somogyi episodes. The brief hypoglycemia is found in the analysis of the Dexcom continuous glucose recording, lasting a total of 10 minutes over a period of 3 days and 21 hours. A repeat continuous glucose monitor recording done March 2012 more prominently displays the hypoglycemia and rebounds. Analysis of this shows capture of 50 minutes of neuroglycopenia in the 3 days and 16 hours. Hypoglycemic infarcts were found on the brain MRI in February of 2012, but were slightly changed from 2008. This is the case history of Molly S., 61-year-old female who complained of her heart racing, and she'd experienced this over the previous 4 years. She had impairment of short-term memory, fainting, ataxia and dizziness, chills with dizzy spells, diaphoresis, insomnia, episodes of severe hypertension with systolic values exceeding 220 at times. She had chest pain, tremulousness, and mild renal insufficiency, and she'd been losing weight. Note that the C-peptide, as in these cases, is usually within normal limits, as opposed to nocidioblastosis when the C-peptide is generally at the upper limits or clearly abnormally high. The Accu-Check line graph once again shows the red X's of hypoglycemia and the hyperglycemia from Somogy rebounds. The GTTID done in 2010 shows both very high sugars, elevated sugars here recorded as 151 at 1 hour, and a low of 38 at 3 hours. This is one cut from her 2010 non-contrast brain MRI showing multiple hypoglycemic infarcts. This is the case of Joelle P., a 16-year-old female with bad headaches for 5 months. She had impaired short-term memory, and she would forget the names of close friends. She had an episode on 4/6/12 while at high school of slurring of her speech. She had been dizzy for the past few days prior. This is her line graph. Joelle, being a teenager, didn't like to check her blood sugar, so this is not as prominent as previous cases, but I think you can see some irregularity there. This is Joelle's GTTID with glucagon thrown in, identifying hypoglycemia with normal insulin values. When we did continuous glucose monitoring on her, you see the hypoglycemia is more readily identified again with Somogy rebounds. Once again, a computer analysis of her continuous glucose monitoring shows that this teenager has 110 minutes of neuroglycopenia, that is, values under 55, in the 4 days and 16 hours of recording. In April of 2012, we repeated the continuous glucose monitor and once again identified the recurrent hypoglycemia with Somogy rebounds. This is the computer analysis of that recording. You see she has 85 minutes of neuroglycopenia in 3 days and 20 hours. And the non-contrast MRI shows multiple hypoglycemic infarcts in this 16-year-old, identified as the white spots that you see. Jeff R. is a 32-year-old male with a chief complaint of fatigue for 15 years. He's having trouble with concentration. He said, "Some days I can't remember my own name." And he's been getting worse for a period of years. He complains of difficulty focusing, weakness of his limbs, some muscle twitching. He's snacking almost constantly. He has frequent headaches, depression, anxiety and panic, flushing and diaphoresis. He wakes in the middle of the night. He has irritability, tachycardia, irregular heart rhythm, difficulty with balance, dizziness and lightheadedness also. Though not as prominent as some of the other cases you've seen, you see both hypoglycemia and hyperglycemia in his line graph. The GTTID in January 2011 picked up his hypoglycemia. Again, note that no hyperinsulinemia was found, but however, the laboratory he went to did not run the specimens as directed. So we repeated the GTID on Jeff and noticed that his insulin levels are low most of the time, and he does once again have the identified hypoglycemia with some OG highs. This is Jeff's August 2011 continuous glucose monitor reading, and you can see the marked hypoglycemia, which at times is almost continuous. And in 3 days and 22 hours of continuous glucose monitoring, notice that Jeff has 160 minutes of neuroglycopenia. Michael M. is a 39-year-old male, initially complaining of nausea, headaches, and fatigue over the past 4 to 6 months. He was told he had borderline diabetes at one time. This was first diagnosed 4 years ago. His lowest blood sugar was 60. He's having periods of shakiness, fatigue, and weakness. He's recorded a high blood sugar of 460 milligrams percent. He has impaired concentration and impaired short-term memory. On one occasion, he said he lost consciousness. He basically, as he's expressed it, lost a chunk of time. He became unaware of his surroundings for about 5 to 10 minutes. This is not uncommon with hypoglycemia from either nocitiblastosis or HH. He has blurring of vision or double vision. He has muscle twitching. He snacks all the time. He wakes up at night to snack. He has headaches. He's depressed. He has panic episodes, flushing, diaphoresis, paresthesias of his face and extremities, difficulty with balance, and dizziness and lightheadedness. Occasionally he has cramping of his stomach also. This is Michael M.'s line graph illustrating this time very high sugars which fall with treatment, and he has hypoglycemia. He's not being given insulin or anything like that. He's being given a TZD and a DPP-4 inhibitor. This is Michael M.'s 4-hour study. Note that we've begun using the serum glucagon. This acts as a smoking gun, and if done properly, will indicate that a hypoglycemic episode has occurred. From time to time, we do have trouble with the lab technicians not drawing samples. See the 3-hour insulin, glucose, and glucagon on this slide. Note that the rebounds are prominent in the patient glucose section. Michael M. has low insulins part of the time, but no elevated insulin suggestive of nocitiblastosis or an insulinoma. The continuous glucose monitor revealed his hypoglycemia. Michael M., February 2012. On this slide, the hypoglycemic episodes are still seen. However, the Somoji rebounds to quite substantially elevated levels are more prominent. Philip Z. is a 44-year-old Hispanic male complaining of a little memory loss. He complained to his neurologist that he had episodes of amnesia in extraordinary circumstances. He had impairment of concentration, he had depression, he snacked a lot, and he felt episodes of tremulousness and headaches. He had occasional tachycardia. Home glucose line graph shows both the multiple episodes of hypoglycemia, an irregular pattern, and occasional hyperglycemia. Once again, we're fortunate to have found the hypoglycemia on a GTT-ID. We did the continuous glucose monitoring November 2011, and this brought out the hypoglycemic episodes. So computer analysis showed he had 70 minutes of neuroglycopenia values below 55 milligrams per cent in 3 days and 21 hours. We repeated the continuous glucose monitoring April 2012, and you can see both hypo and hyperglycemia. Again, see the neuroglycopenia at 45 minutes in 5 days and 19 hours. So he's improved and he feels better, but his disease is not gone. Gail E., a 57-year-old female, presents with numbness of her heel of the left foot and of several toes on both feet since July of 2010. She has paresthesias in the great toes, thumb, index, and the index finger of her hands. She has shooting pains, impairment of short-term memory, impairment of concentration. She had what she calls a loss of consciousness, but this is sort of a time distortion, which is common to these patients. She has anxiety, depression. She sees spots in her visual field that she describes them as whirly things in peripheral visual fields. She has palpitations, occasional hypertension, and fatigue and thirst. Again, the graph of the home glucose sugar readings shows both high and lows. And on the GTT-ID, the hypoglycemia shows, and the insulins are actually rather low most of the time. So to bring out the hypoglycemia, we advise doing a continuous glucose monitoring, and you'll see the lows with this emoji rebounds. So the computer analysis in 3 days and 21 hours shows 55 minutes of neuroglycopenia. After treatment by January 2012, although we still see the hypoglycemia, the recording's much improved. And this is the computer analysis of her January 2012 continuous glucose monitor, which lasted 4 days and an hour, showing that she has no more neuroglycopenia and only 40 minutes of mild hypoglycemia between 55 and 70. So in summary, when one is presented with a patient with episodic symptoms even, one must do a continuous glucose monitor and a 4-hour GTT to identify any elevations of insulin, which would be characteristic of insulinoma or basidoblastosis, and this less common but not uncommon syndrome of hypothalamic hypoglycemia. Thank you.